Hi, everybody. It's such an honor to be part of Hill Day this year on behalf of the IFFGD. I'm going to talk to you today about the role of supplements for functional GI disorders with a particular emphasis on the irritable bowel syndrome or IBS. So, by way of introduction, functional GI disorders are conditions that are defined by the presence of bothersome GI symptoms, gut symptoms, that reduce patients' quality of life and their ability to carry out their daily activities. These conditions can affect any part of the gastrointestinal tract, spanning from the mouth all the way down to the anus. The most common functional GI disorders are functional dyspepsia, which is defined by the presence of upper GI symptoms like upper abdominal pain, nausea or fullness, feeling really full after eating only a small amount of food, and then irritable bowel syndrome or IBS, which is thought to be more of a lower GI condition, defined by the presence of abdominal pain in association with altered bowel habits. So that can be either diarrhea, constipation, or a mixture of both diarrhea and constipation. By definition, these conditions have no obvious structural cause. That is, something like an ulcer or a cancer by upper endoscopy or radiology testing. And they affect between a quarter and a third of the general population. So in the United States, somewhere between 1 in 4 and 1 in 3 individuals in the US population will have at least one of these different functional GI disorders. Sometimes patients will even have more than one. It accounts for billions of dollars in healthcare expenditures. And there are a number of FDA approved medications. That's the good news. The bad news is that these FDA approved medications tend to improve symptoms in fewer than half of patients with these diagnoses. And in addition, these medications can cause significant side effects and are oftentimes not covered by insurance. So patients are left to their own design in terms of finding solutions for their GI issues. These conditions have a wide range of proposed causes. So it's people are largely thinking about functional GI conditions as arising from the interaction between the environment and the innate characteristics or underlying physiology of the individual. So things like environment interacting with genetics, and also with an overlay of things like stress and anxiety, early life events like a history of abuse. Medications can certainly cause GI symptoms in many individuals, and enteric infection or gastroenteritis, so getting like traveler's diarrhea or food poisoning, can actually lead to the development of these conditions by changing the bacteria, viruses, fungi that live within our GI tract, the so-called microbiota, and also altering the leakiness or permeability, that's the medical term, of the GI tract, and leading to exposure of things in the GI tract to the immune system that resides within the wall of the GI tract, and then can lead to a cascade of events affecting the contractile activity, the sensation in the GI tract, and even cognitive emotional function. So, functioning of the brain in your head. This slide gives you an idea about the current thinking about how these different parts interact. So things in the lumen of the gastrointestinal tract, like food, like the bacteria that live inside the GI tract, things secreted into the lumen of the GI tract, like bile acids, affect the immune system in the GI tract through the layer of cells that lines and provides a barrier separating the stuff in the lumen from the immune system in the GI tract. And that's the whole concept of permeability, or the level of leakiness of that membrane of cells that actually keeps what's outside from getting inside. Now, when we think about treating these functional GI disorders, the treatment reflects that heterogeneity of pathophysiology that I just talked about. So, in other words, because there are a number of different potential causes for symptoms in an individual patient, different treatments will work better or worse in individual patients. In general, we have a scheme that we tend to use in patients with functional GI conditions like functional dyspepsia and IBS. So, obviously, the way that we treat and the aggressiveness of our therapies is going to be different in individuals that have very mild symptoms or very infrequent symptoms, as opposed to individuals that have more frequent, more severe symptoms. So we tend to always start with the consideration of how diet and lifestyle may influence symptoms in patients with these functional GI conditions. So every patient, mild, moderate, or severe, we think about diet and lifestyle. We want to make a definitive, confident diagnosis. We don't want to leave patients wondering about their diagnosis. We want to make a diagnosis of functional dyspepsia or irritable bowel syndrome or any of the other functional GI disorders that one could diagnose, again, from the mouth all the way to the anus. We want to make sure that patients understand that diagnosis and what it means for them going forward. So, what to expect, what things not to expect in association with having the diagnosis of functional dyspepsia or IBS. In fact, a lot of times when patients have mild or infrequent symptoms, with just making a confident diagnosis, helping patients to understand what is going on, and recommending some over the counter medications on an as needed basis or some dietary or lifestyle changes, that's oftentimes all they need. On the other hand, when patients have more moderate or severe or more frequent symptoms, we oftentimes have to use things like over the counter or prescription medications. We have to think about more radical changes in diet. We may want to think about behavioral strategies like cognitive behavioral therapy or hypnosis. And when we get to that group of patients who are severely affected, we're almost always thinking integratively, holistically. That is, thinking about not just medications, but also a strategy that incorporates diet, behavior, as well as medications, and really as equal partners in the care of patients with these conditions. In fact, I would even go so far as to say that in 2020, an integrative, collaborative, team based approach is really the standard of care for patients with severe, frequent symptoms in the setting of functional GI disorders like IBS or functional dyspepsia. Now, today we're going to focus on supplements because while traditionally, medications, diet changes, behavioral therapies are all things that an experienced doctor or healthcare provider will discuss with their patients. But oftentimes, patients will be very interested in the use of supplements that they can buy over the counter from the health food store, the drugstore, or the grocery store. So what I'm going to try to do today is give you an idea about where there is evidence to support the use of some of these commonly utilized supplements for functional GI conditions. And most of the data, just realize, really focuses on functional dyspepsia and IBS. So that's what we're going to talk about for the most part. We're going to talk about peppermint oil. We're going to talk about an herbal remedy called STW5 or Iberogast. We're going to talk about glutamine, aloe vera, melatonin, and finally, a new concept that is functional foods or prebiotics. We're not going to talk about, although some patients utilize these supplements I'm going to mention in a moment, we're not going to talk about turmeric, artichoke leaf extract, and we'll say a couple words about cannabis. But the reason we're not going to talk very much about those particular supplements is because there's essentially no data in patients with functional dyspepsia or IBS, or the data that exists actually suggests that they don't work. So, in my mind, these are not currently evidence based treatments for patients with IBS or functional dyspepsia. So let's start off where there is evidence. And let's start off where there's the most evidence, and that's with peppermint oil. Peppermint oil is the most evidence based supplement for both functional dyspepsia and irritable bowel syndrome. Of course, peppermint oil is derived from the plant Mentha peperta, and the active ingredient of Mentha peperta is L-menthol or peppermint oil. It's been used to treat dyspepsia and IBS literally for centuries. And it has a number of well-documented effects in the GI tract. So, for example, it tends to relax the muscle in the GI tract through effects of blocking calcium channels in the GI tract. It also has effects on certain types of serotonin receptors. Serotonin is an important neurotransmitter found in the brain and the GI tract, and it's thought to be very important both to motor function, so contractile activity, and sensation in the GI tract. Peppermint oil seems to have effects on that serotonin system. It can be purchased either in liquid or capsule formulations, and overall, it's generally well tolerated. Some patients, however, particularly when they take uncoated peppermint oil preparations, will report problems with heartburn. Less often, patients can develop problems with nausea, vomiting, diarrhea. There's a occasional rare patient who will be allergic to peppermint oil, so be aware of that. Also, peppermint can sometimes lead to an exacerbation or worsening or triggering of asthma. And then finally, rare cases of atrial fibrillation, a heart irregularity, have also been reported in patients using peppermint oil. There are two studies I want to highlight for you in this presentation. One deals with patients suffering with functional dyspepsia, so those upper GI symptoms of either upper abdominal pain or extreme fullness after eating only a small amount of food or nausea. Realize that the combination of Carraway oil and L-menthol, so peppermint oil, actually has been found to improve those upper GI symptoms in a number of studies. In the 80s and 90s, there were a number of studies comparing to placebo, showing that Carraway oil and L-menthol was better than placebo at improving those upper GI symptoms in patients with functional dyspepsia. In this study that's depicted on the slide, we found that Carraway oil and L-menthol did better than placebo in patients taking usual treatments for functional dyspepsia. So taking acid blockers, Pepto-Bismol, a variety of other treatments that patients commonly use for their upper GI symptoms. Carraway oil and L-menthol led to rapid relief within 24 hours in many of these patients compared to placebo. Now, what we found was that using the medication as needed was probably better than using it persistently, because you can also see from the slide that after 28 days of use, there was small but non-significant differences between using the Carraway oil and L-menthol compared to placebo in these individuals on other treatments for functional dyspepsia. So what I usually recommend to my patients is if they're still struggling with their dyspeptic symptoms despite taking an acid blocker, for example, like a drug like an H2 receptor antagonist or a proton pump inhibitor, using this medication on an as needed basis can be very effective at helping to relieve their symptoms of dyspepsia. Peppermint oil has also been found to be beneficial for the treatment of irritable bowel syndrome. So this is a study that evaluated triple-coated peppermint oil for patients with IBS and found that triple-coated peppermint oil did better than placebo for abdominal pain or discomfort, bloating, which is obviously a really common and bothersome symptom for patients with a whole range of different GI conditions, and also pain during passing a bowel movement. So peppermint oil, good for upper symptoms as well as lower symptoms. The next supplement I'm going to talk about is called STW5 or Iberogast. This has been studied both in functional dyspepsia and IBS, and it's a combination herbal supplement consisting of 9 different proprietary herbs, which are listed on the slide here. And you notice, interestingly, that this herbal supplement also contains peppermint oil and caraway. So what we talked about just in the previous couple of slides, this combination herbal supplement seems to have antispasmodic effects, so it relieves spasm in the GI tract, and also may affect sensation within the GI tract. STW5 has been studied in several studies actually for patients with functional dyspepsia. Actually, in this meta-analysis, so a study where all the different randomized controlled trials were combined to assess the overall effectiveness of STW5 in patients with functional dyspepsia. Data from three different placebo-controlled trials, including 273 patients with functional dyspepsia, was combined. The STW dose was 20 drops or 1 milliliter given 3 times daily for 4 weeks. All the trials evaluated another formulation of the STW5 in addition to the STW5 containing those 9 different herbs. Symptoms assessed included regurgitation, upper abdominal pain or epigastric pain, dysmotility symptoms like things like fullness after eating a small amount of food or nausea, as well as vomiting. And adverse events with STW5 were very similar to placebo. There were no serious adverse events reported in these three trials. And what you can see from the graph on the slide is that after 4 weeks of STW5, there was a much higher proportion of patients reporting mild or absent symptoms. So 60% on STW5 versus only 28% with placebo. In addition, if you looked at it another way, the proportion of patients that were reporting severe or very severe dyspeptic symptoms, STW5 only 7%, placebo was 26%. So STW5 appeared to improve selected upper GI symptoms in patients with functional dyspepsia in these three randomized controlled trials. There's also one randomized controlled trial of STW5 for IBS, irritable bowel syndrome, including 208 patients with all different subtypes of irritable bowel syndrome. So IBS with constipation, IBS with diarrhea, IBS with a mixture of constipation and diarrhea. And bottom line is you can see that around 50 patients were randomized to receive traditional STW5 versus 50 patients with placebo. And then there were some derivatives of STW5 that were also evaluated in the study. And bottom line is that STW5 did better than placebo for improving abdominal pain and overall IBS symptoms. Other studies have shown, though, that there are rare cases of liver toxicity, and that's something to be aware of. So, if you were, for example, an individual with known liver disease, you probably would not want to use STW5. In addition, it's also important for patients to understand that taking this particular herbal supplement can interfere or change the metabolism of drugs that are broken down by a certain enzyme in the liver called CYP3A4. And these would include drugs like acetaminophen or Tylenol, diazepam or Valium, codeine, which is a pain medication. So, and this really highlights a really important point for patients, and that is that it's very important to tell your doctors about all the things that you're taking. So, not just the prescription medications, not even just the over the counter medications, but also supplements. Because remember that occasionally supplements can affect the way other drugs that you're taking, whether it be prescription or over the counter, are broken down and how long they hang around in your body and affect a variety of different functions in your body. Now we're going to turn our attention to glutamine. So remember that glutamine is an essential amino acid and it's an important energy source for rapidly dividing cells. Well, where are the most rapidly dividing cells in the human body? In the GI tract. Actually, in the lining of the GI tract are the largest number of rapidly dividing cells. So in this trial that was sponsored by the National Institutes of Health, 106 patients with IBS and diarrhea that occurred after an acute gastrointestinal infection. So this is not any IBS patient. These are patients with IBS that occurred after an acute gastroenteritis or an acute GI infection, so called post-infection IBSD. These patients were randomized to glutamine, 5 grams 3 times a day, so a pretty big dose of glutamine, versus placebo 3 times a day for 8 weeks. And the primary outcome was overall improvement in IBS symptom severity score. And if you look at the table, what you can see is that glutamine did significantly better. 80% reported significant relief or statistically significant improvement of their overall IBS symptoms, compared to only 6% with placebo. And that was obviously highly statistically significant. If you just looked at the IBS symptom severity score, again, significant improvements with glutamine versus placebo. Stool frequency, as well as the consistency of stool, did better on glutamine than with placebo in these patients with post-infection IBS. In addition, these authors found that glutamine also appeared to improve the leakiness or permeability of the GI tract. So, some very promising preliminary work in a specific subgroup of individuals with IBS, those individuals with IBS as a consequence of an infection in the GI tract, or like food poisoning or traveler's diarrhea. We certainly want to see additional studies in patients with IBS in general. We also want to see larger studies which confirm and validate these results. So, one promising randomized controlled trial in post infection IBS. Next, we're going to talk about aloe vera and IBS. Aloe comes from a succulent that has two components, a gel and a latex. And there are a variety of different health effects associated with the use of aloe. It possesses known stimulant laxative properties, and probably aloe is best known as a natural stimulant laxative. But it also has possible anti-inflammatory properties, and for that reason is thought that it may be beneficial in terms of providing pain relief. It turns out that there are several small studies that have evaluated aloe vera in patients with IBS, enough so that there was a meta-analysis done. And so again, investigators actually combined the data from these three small studies, which included 151 patients with IBS. And in their intention to treat analysis, that is, all patients that received drug or placebo were included in this analysis. Aloe vera did better than placebo at relieving overall IBS symptoms. Now, the risk reduction ratio was 1.69. Now, realize that most of the time when we see risk reduction ratios of less than 2, we're somewhat skeptical about how strong of a result this really is. So, interesting and promising preliminary data from small studies, but by no means definitive. I want to make sure that people realize that by no means is this data definitive, although it's pointing in the right direction. The side effects, most common side effects, not surprisingly, are diarrhea, and aloe vera can also cause a darkening of the lining of the colon, which fortunately doesn't hold any significant health consequences, but is important to realize when you're undergoing a colonoscopy. Also, aloe vera can also affect the absorption of other types of drugs. So certain anticoagulants, as well as oral diabetic medications, the absorption of these types of medications can be changed by concurrent use of aloe vera. Again, really important to make sure that you tell your healthcare provider about all the things that you're taking, so that they can take that into consideration and make sure that you're safe. Realize too that in 2002, the FDA removed aloe latex products from the US marketplace, primarily because the manufacturers had no data to really support whether these products were safe or not. So there are still aloe gels, but not latex products in the United States. Melatonin. So melatonin is a neurohormone released by the pineal gland in the brain in a circadian or rhythmic pattern throughout the course of the day, largely driven by exposure to sunlight. And melatonin exerts local effects in the gastrointestinal tract, and realize that it's structurally similar to the neurotransmitter serotonin, which is found in the brain as well as the GI tract. and is thought to be very important in the normal function and sensation in the gastrointestinal tract. There are three small randomized controlled trials which have evaluated melatonin in patients with IBS. One done at the Mayo Clinic, and 40 patients with IBS were randomized to receive melatonin 3 milligrams at bedtime or placebo for 2 weeks. This study found that mean abdominal pain scores improved with melatonin to a greater degree than with placebo, but there were no changes in bloating, in stool consistency, and how often people reported going to the bathroom, and in their level of anxiety, depression, or their sleep. In the second randomized controlled trial of 18 patients with IBS using the same dose, melatonin 3 milligrams at bedtime versus placebo, these authors reported improvements in overall IBS symptoms and quality of life. And in the third randomized controlled trial of 60 IBS patients who received melatonin 3 or 5 milligrams versus placebo for 6 months, they found that visceral pain, pain related to the GI tract, improved at months 4 and 6, but only in the patients with IBS and constipation. So you can see this is a bit of a mixed bag, and all these studies are very small. So again, the good news is in these small studies with significant issues, things are pointing in the right direction, but by no means should this be considered a definitive data set to support widespread use of melatonin. Also wanted to mention about the concept of prebiotics or functional foods. Okay, so you've all heard of probiotics. So probiotics are bacteria which, when given in sufficient quantities, exert some health benefit. Prebiotics are actually poorly absorbed, selectively fermented short chain carbohydrates, which allow targeted changes in the GI microbiota. And so the idea here is rather than giving the bacteria, we give the food for the bacteria that are potentially beneficial. Also, synbiotics, which are a combination product containing a prebiotic and a probiotic, and then postbiotics, which are actually dead bacteria. So the idea of the contents of the cell or the cell wall in some way exerts some beneficial health effect rather than the actual live bacteria. But we're going to focus on prebiotics, which introduces this concept, which I've already mentioned, of functional foods. I think this is another concept for the audience to be aware of. This is a modified food that claims to improve health or well-being by providing benefit beyond the traditional nutrients it contains. So it's something more than the nutritional value that leads to a health benefit. And so the question is there evidence that prebiotics are beneficial for patients with functional GI disorders? And the answer is yes, there is. In fact, a very interesting study was recently published from the group in Barcelona, which evaluated the combination of a prebiotic with the Mediterranean diet versus a placebo plus the low FODMAP diet in patients with functional GI disorders, most of which turned out to have irritable bowel syndrome. And they actually found that after 4 weeks of this prebiotic and Mediterranean diet, versus the low FODMAP diet, both of these interventions led to statistically significant improvements in overall GI symptoms, and that the magnitude of benefit was similar between the prebiotic and Mediterranean diet versus the low FODMAP diet. So this study would suggest that a prebiotic is potentially as effective as a low FODMAP diet. Of course, a really important potential issue to take into consideration is we don't know how much or how little of that benefit was actually created by giving a Mediterranean diet. In fact, one of the things that I would really like to see is whether or not a Mediterranean diet alone is effective as a treatment for patients with IBS. I guess time will tell. We'll see as more studies become available. Next, I want to say a couple of words about cannabis, not so much because cannabis is an evidence-based treatment for functional GI disorders. It's not, but more so because patients are increasingly asking about whether they should be thinking about cannabis or CBD oil as a treatment for their GI symptoms. So, marijuana is otherwise known as the cannabis sativa plant. and has been used recreationally and also as a treatment for a variety of different medical conditions. Now, it's important to realize that cannabis sativa or marijuana contains many, many different chemicals. In fact, over 100 chemicals have been isolated from marijuana, so-called cannabinoids. And these include THC, which you've probably all heard of. THC, of course, is the part of marijuana, the chemical of marijuana that's responsible, most responsible for its psychoactive properties. CBD, on the other hand, has no psychoactive effects, unlike THC, but also but nonetheless has effects in other parts of the bodies and has been utilized, for example, as a treatment for pain. CBG, you may be less familiar with. This is another cannabinoid, so another derivative, chemical derivative of marijuana, that again has no psychoactive properties, but may offer benefits for other types of conditions, again like pain. Receptors found in the can be found in the brain and in the periphery, including nerves and muscles in the GI tract. So it's logical that people are starting to question whether or not derivatives of marijuana or marijuana itself might be beneficial for GI symptoms. There are currently no studies of marijuana or CBD oil in functional GI conditions that I'm aware of. Marijuana can cause not only CNS symptoms, which is, of course, why it's popular recreationally, but also can lead to significant GI symptoms, and in particular, something called cannabinoid hyperemesis syndrome, which is a condition where individuals that smoke large amounts of marijuana on a regular basis will develop recurrent bouts of severe nausea and vomiting to the point that they'll have to go to the emergency room for intravenous fluids and intravenous antiemetic medication. So this can be a very serious condition. In fact, before our recognition of the association with marijuana, all of these patients we used to label as suffering with something called cyclic vomiting syndrome. Now, there are still patients that have cyclic vomiting syndrome, but those individuals with symptoms suggestive of CVS who are smoking marijuana most commonly have cannabinoid hyperemesis syndrome. And the treatment for this is stopping smoking marijuana. It'll go away if you stop smoking marijuana. There are studies with derivative medications that affect cannabinoid receptors. So there's actually a drug that acts as the CB2 receptor, which is being developed for irritable bowel syndrome. That drug is in clinical trials in the United States at present, so we'll see whether it works or not. So to summarize, functional GI disorders are really common and they have many causes. And because of this, there are many potential solutions. The solution for one patient may not be the same as the solution for another patient. Though patients often use supplements, doctors are rarely knowledgeable about them and usually don't recommend them. So it's going to be really important to make sure that you have an open two-way dialogue, with your doctor about all the things you're taking, over-the-counter medications and supplements. Peppermint oil offers benefits for functional dyspepsia and IBS, probably the most evidence-based supplement at the current time. SGW5 may offer benefits for functional dyspepsia and IBS. Glutamine, in a well-done randomized controlled trial, was found to be beneficial for post-infection IBS, so IBS occurring after an acute episode of food poisoning or traveler's diarrhea. Aloe vera possesses laxative properties. That much we know for sure. It may benefit other symptoms in IBS, although that's less well proven. Melatonin may improve abdominal pain in patients with IBS, but again, very preliminary data. And finally, prebiotics are promising functional foods that may offer benefits for patients with IBS. A recent trial suggesting that prebiotic plus a Mediterranean diet does just as well as a low FODMAP diet. So a lot of information. I hope you found it helpful. Hope you learned something and that it'll help you to think about and perhaps better manage your GI symptoms. I hope you enjoy the rest of the Hill Day. Thanks so much for your attention.